Hey, everybody. Good afternoon. I'm Carl Schuessler, the moderator for the panel today to discuss alternative payment models. However, before I introduce the panel members, I've been asked to mention a few informative housekeeping notes. One, since this is a part of the FLAACOs virtual conference, this session has been pre-recorded and is being played back at the time slot on the conference agenda. Secondly, even though the session has been pre-recorded, the panel members are currently available to respond in real time using the chat box feature on your screen. Also, thirdly, please know that there will be no dedicated Q&A at the end of the session. Instead, if you have a question, please type it in the chat box during this discussion and we will respond accordingly. Finally, the recorded session is limited to 45 minutes, so we will get as many questions in as we can during that time. There will be no Q&A after. You have to do it in the chat box. Finally, the Commission on FLAACOs panels has asked me to conduct this in a strict fashion, and each panelist will only have a limited time to answer the questions. And if anybody gets a little too loquacious, then they're going to be asked to nip it in the bud, and then they will be buzzed and potentially muted. Also, before I go, I wanted to say there's a big football game this weekend for all you Floridians. I'm a Georgia Bulldog, and it's been 1,468 days since those stinking tank top jort wearing Gators have beat my Bulldogs. So hopefully they'll continue the streak this weekend. Now I want to open it up and introduce the panel. And I'll start with Tim Koehler, Bluestone Physician Services. Tim, you're on the clock. You have 30 seconds.
Hi, this is Tim Koehler from Bluestone. I'm the Chief Operating Officer of Bluestone. We're a primary care clinic that provides services, medical services to people living in residential care settings. We have about 17,000 patients in about 7 markets in 3 states in Wisconsin, Minnesota, and Florida.
Okay, great. All right, Dr. Dickerson, you're up.
Hello, everybody. I'm Cristin Dickerson. I'm a practicing radiologist in Houston, Texas, and I own a company called Green Imaging that offers a national network of affordable, high-quality medical imaging centers for self-funded employers, cost containment companies, and even individuals nationally.
Chris Yarn, Walk On Clinic, you're up.
Hello, how you guys doing? My name is Chris Yarn. I'm the CEO of Walk On Clinic. We run a company that brings on-site primary care to employer groups by putting these mobile clinics that you see right here behind me on wheels to all these self-funded employer groups, providing the same patient experience you would expect in a brick and mortar facility, but more convenient access to care for the employees. That's it.
All right.
I didn't get buzzed.
Kellie Jackson of PayerCompass.
Good afternoon. Thanks for having us. My name is Kellie Jackson. I'm Vice President of Sales and Client Engagement for PayerCompass, based out of Dallas, Texas. We are a healthcare technology company in the cost containment space, do a lot of reference-based pricing, but also work with self-funded employers and the various other organizations helping self-funded, really bringing transparency of what the cost of care is. So looking forward to talking more about that in this session.
All right, thank you, Kellie. Barry Murphy, FairCo Self Plan.
We're delighted to be here. My name is Barry Murphy. I am a street benefit advisor. I've been doing it about 48 years. And I partnered with Carl about 8 years ago in a specific new direction that we reference as actively managing a health plan. And that includes bringing together many of the resources on the panel here with us today, as well as others, to take a more active role in managing healthcare costs and eliminate the middlemen.
All right, thank you, Barry. All right, Tim, we'll go to you first question. What is appealing about the current ACO models, Tim? And I'll give you 60 seconds this time. Tim?
ACO, can you hear me?
We did not. You want to start back over?
Okay. Can you hear me now?
Yes, sir.
Okay, we have one thing I didn't mention in our intro is we have a large ACO, 6,000 patients in our 3 markets. And what is exciting for us about the ACO is really taking on higher levels of risk, and that will allow us to change our models of care. So right now we only get paid if we send a physician or one of our advanced practice providers in to provide a service. But what our patients need, these high-risk populations, often is they need social workers, and they need care coordinators, and they need navigation across the healthcare system. And changing the models of care by taking on more risk and having more of the healthcare dollar to work with will allow us to change those models. And we find that pretty exciting.
Okay, thank you, Tim. All right, Dr. Dickerson, why do you feel direct contracting for imaging is the easiest first step in changing from a traditional health plan to a more actively managed plan?
It's a great first step. It doesn't require much change. It's not somebody moving the employee's cheese. It is actually, they see it as a benefit, especially if it's not rolled out at re-enrollment. If it's rolled out mid-year as a true benefit to them with a low copay or zero out of pocket, it's a great way to save about 60% on the medical imaging spend in a health plan.
Hey, wow. Okay. Thank you, Dr. Dickerson. Chris Yarn, are your alternative payment models only available regionally or nationally? And what is the scalability of how many practices within an ACO you can serve? So you have a two-part question.
Yeah. So we started as a Florida-based company serving here in Florida, working with a lot of independent physicians, giving them scale. So they want to extend into another area. They have, a much larger scalability. When COVID testing here happened recently, we figured out ways to take a little small primary care practice and help them see 500 patients in a day. So obviously it's a good alternative payment method for them. Our availability to scale into different markets is completely different than the traditional brick and mortar model. We're at about 1/20th the cost to put a clinic on site that can see 100 patients in a day. And we can be in pretty much any market in the US within 30 days. If an ACO had a need for, 10 or 20 mobile units to be deployed or something like that of a larger ACO, then you're probably looking at more like 30 to 60 to 90 days to deploy something at that scale.
All right. Thank you, Chris. Man, you just beat it too. You just beat the buzzer.
Well, my goal is to just not get completely shut down by the buzzer. That's my one mission today.
All right. Well, we just don't want you talking over everybody or starting to go break into a Frank Sinatra tune and with your other AKA Frank Mic Dropper personality. Barry Murphy, we're discussing alternative payment models. FairCo's is a health plan. Why should a broker advisor health plan be part of this discussion today?
Well, I think that you've brought together several very good resources on this panel. And of course, there are others that are not part of this program as a result of space and time requirements. But someone has to put this all together and coordinate it and integrate it through a common database in order to optimize the impact on each individual resource's contribution to the greater whole. So we operate as somewhat as the central nervous system. We also perform a marketing function to bring these resources to the self-funded market.
All right, thank you. Kellie Jackson, the slow talking Kellie Jackson from Dallas. Kellie, talk to us a little about reference-based pricing as an alternative payment model that has become a frequently mentioned option for employers and to be able to continue to provide health plan benefits for their plan members. And what are the advantages of a reference-based pricing plan?
Sure. So reference-based pricing is, in its core is trying to bring down the cost of healthcare, primarily in big hospital claims. It can be used in various ways. I mean, there's some employers who will forgo all networks and just do reference-based pricing. That's a big leap. But reference-based pricing can be part of many other arrangements. It can be a wrap through a lot of direct contracting. It can live alongside networks as an out-of-network solution. So it's a tool. It's another tool. You got to have a lot of tools in the shed to bring down the cost of care and yet provide quality care to your members. So it can help bring transparency into your direct contracts. Getting a direct contract, having as Dr. Dickerson said, just carving out a piece of it and having, imaging direct contracted, and then maybe using reference-based pricing for your facility claims or your out-of-network claims. So it's an option to bring down cost, at the same time paying providers a fair and equitable rate.
All right, great. Hey, you didn't happen to have any of that stuff you guys sent me over, because you're talking a little slower today.
Trying to do my best to slow it down for my Georgia friends.
All right, thank you, Kellie. All right, Kellie, follow-up question. How receptive are providers, say some of these ACOs or whatever, are plan members to reference-based pricing?
It depends on the market. Some markets, reference-based pricing is certainly more, accepted than other markets. A lot of it's education, explaining, what the reimbursement is, having a conversation with providers and payers as to what reference-based pricing means. Having it as a piece of the whole solution that, as Barry mentioned, somebody's got to bring all the solutions together. So it's not the only one. It can be wrapped and packaged with DPC, walk-on clinics, direct contracting with providers. And once I think you get in front of people and explain what it is, and processes of how you're going to work with members, work with payers, and the plan to, the goal is to lower cost of care for the plan and for the members. So it's accepted in different ways. Certainly some markets are more accepting than others. It is certainly a newer, idea. And so, we do a lot of it in some areas, and there's some areas of the country that it is really relatively new, and, more education needs to be done.
Well, it's Kellie, you say that. It's funny, my Mr. Murphy over here, he's always said most of the hospitals don't have a problem being reimbursed tied to a metric of Medicare. It's just what level that metric is their problems, because it is accepted all over America at all the hospitals. All right, Chris, when working with an independent primary care practice, what alternative billings have you brought them that they have liked the most?
Yeah, I mean, outside of, the traditional employer stuff where those are good contracts for, an independent practice to get, COVID has been a big biller for these physicians that need a way to test outside of their office space and do large scalability. Like I mentioned before, I think the biggest thing that we do for these medical practices is they make money every time we work with them. So where you might, pay an internet marketing guy to get you a couple thousand patients a month or something like that, we literally move the clinic 3 times or 4 times a month and get you to that 1,000 patients. So it's really just about being intelligent about how you're going to deploy the convenient access to care to where the patients are. And then still integrating all those same continuation of care practices that the primary care office already has in place. And I would mention one other thing, since it's an ACO conference, it's also a way to population health manage and increase your hitting your metrics. So if you've got an area in your ACO or practice that's not performing well, you can make the convenient access more convenient for that group of people, and then use it to deploy your, annual wellness exams for Medicare. Just depends on the scope of the practice.
Okay, thanks, Chris. Just follow up for you real quick. How do you see the post-COVID era affecting those opportunities in the future?
So I think the 2 big winners coming out of COVID are, telemedicine as a technology, and then I think mobile healthcare as well. And I think most people are paying attention to telemedicine, but you just saw Advent Health Systems switched everything to Zoom. So you have all these big tech giants, Zoom, Facebook, Google, WhatsApp, Messenger, all of these platforms now that are now overnight HIPAA compliant and that are being used as a telemedicine platform. So what that's done is it's given connectivity to all these practices in a digital format in a way where consumer utilization is finally up. But there's still thousands of billable services that cannot be done in a telemedicine type fashion. So what I think it does is, I think in the post-COVID era, you've got a great opportunity as a practice to extend your scope of services and the reach of your brick and mortar facility, and then continue those billable services through telemedicine offline. You can go touch a patient population 20 miles away from your clinic in a walk-on clinic for a day and then capture all that patient data in your EHR system and then continue to go through. And I'm sure there's some remote patient monitoring companies that are at this conference as well that can integrate into that process. So it's about kind of being able to still do the physical inhuman stuff, and as well as, the connectivity of telemedicine now. So.
All right. Well, I don't think we'll call on you anymore. You
You're buzzing me there on that one.
You went way over your time there.
Well, I'm waiting for the guy to pop up and buzz me off stage.
We might come back to you. Maybe we'll decide. All right, Dr. Dickerson, how is direct contracting? How might that arrangement be structured?
Direct contracting can happen a lot of different ways. If there is a traditional TPA in place for a self-funded healthcare plan, the green imaging is bolted on like vision or dental. And, we have suggested plan wording for that. If it's an independent TPA, it can be written into the plan, but once again, we like it not at re-enrollment. So the best way is a plan amendment, because we want the employees' full attention to this, and we want them to see it as a benefit, not just some other way that they're being, sent somewhere that they don't want to go.
Okay, good. Thank you. Tim Koehler, we asked you a minute ago what you thought was appealing about the current ACO models. What would you like to see change? What could improve them?
I think, specifically for us is, we're really focused on high risk patient management. And so we've got a very atypical population from a normal ACO that may have a general swath of members across the, large Medicare population. So the challenge for us is we've got this really high, very acute population, and our benchmark set though is modified to, modified down to, because they assume that we're more like a normal ACO. So it's a challenge for us because our costs are, twice, 2 to 3 times what a normal Medicare patient is. And so there's lots of opportunity within that population to manage costs and ED visits. But when we're being compared to a normal Medicare population, it's really difficult to get the outcomes that we're looking for. So I'd like to see more focus within the ACOs on some of these discrete populations and kind of some changes to how the benchmarks are set and those kinds of things to better accommodate these really high risk, high cost populations. I think the current methodology has some flaws. So that's an area where we're trying to engage with CMS and CMMI on future ACO models.
All right, thank you. Mr. Murphy, what other functions does FairCo perform?
Well, as I mentioned, we've created a platform, so we provide overall guidance and oversight. We start with the administrative partner, a TPA, that is capable of working with the individual resources that we bring to the party. And then we arrange for the risk component. And my friend Tim pointed out the risk element in an ACO. And if you are an ACO that is going to assume some risk, the more control and cost containment, the better. We wrap all this together with what we call a weaponized plan design. In the city of Jacksonville, you can spend anywhere from $36,000 to $115,000 for a knee surgery. And yet the typical health plan, the cost to the employee is the same wherever they go. We believe in trying to drive down out-of-pocket costs for employees by providing a higher level of guidance and steerage, if you will, to our directly contracted partners, or where quality and cost are indicative. So you might have no out-of-pocket if you go to one hospital, but you're normal and regular out-of-pocket if you go somewhere else. So we just wrap everything together. And we're also, because this is an alternate and different delivery system, we're responsible for educating employees and how to best utilize the benefits that the employers put in place.
Okay, thanks, Barry. Kellie, a thought for you. What partnerships do you feel or need or factors should you consider when weighing the options to switch to a reference-based pricing plan?
Good question. Like Barry said, you need partners. And so typically it starts with a broker consultant. You need somebody who understands that there are alternatives out there, and these alternatives are going to save the plan and the member money. So certainly, broker consultant typically is where a lot of these arrangements get pulled together. Need a third-party administrator who can think outside the box and not just plugging in your standard renewal, and look at connecting with other organizations. You need maybe it's DPC or walk-on clinics, things like that. Maybe it's getting direct contracts with very specific targeted providers. And then certainly we would think you could use the benefit of an excellent reference-based pricing vendor, whether you're paying reference-based pricing rate or you just need help with the technology piece of really understanding the cost of care and having tools to help members navigate high quality, lower cost options.
Okay, thank you. Tim, what payer trends do you see emerging in your market?
Specifically because we deal with these high cost populations, we're seeing a lot of payers get into the ISNP space, the institutional special needs plans, and starting to focus on these more discrete populations and the extreme cost of some of these populations. And you used to only be a few ISNP plans in the marketplace at all, and as United had a plan, but it was mostly focused on SNF. And as I think value-based pricing and as some of the uniqueness of these populations has started to spread throughout the marketplace, we see more and more plans entering and taking advantage of those mechanisms to manage higher cost and higher risk populations.
Hey, Tim, I one other question, for a middle Georgia boy who just fell out of a deer stand, when you say SNF, I start sniffing. I assume you mean skilled nursing facility?
No, I was actually saying SNP in that case, which is a special needs plan, which is focused on population that may have a diagnosis or have a situation where like they live in an institutional setting like a skilled nursing facility or assisted living, memory care in our case.
Okay. All right. Well, thank you. I appreciate clarifying that for a slow-witted, balding man. Thank you. All right. Chris, why should an ACO with a large footprint of brick and mortar facility partners need a mobile solution? Aren't mobile healthcare solutions more for rural healthcare?
Yeah, I would challenge that thought process of, why would retail stores 20 years ago need distribution channels? Why would Target or Walmart or Kmart with these massive retail footprints need distribution stations, right? And then they got slaughtered by the guy, they're paying $7 a square foot retail, and they got slaughtered by the guy that's doing 30 cent per square foot distribution centers. So I think we are in a different world now than we were before. And the more convenient access you can provide, the better you're going to. You can even just look at the success of the Minute clinics inside of the CVSs. They literally took a retail footprint with closer geographic areas to all these residential properties, and the patient populations exploded. So I think it's just, you've got to do whatever you can to stay competitive in this quick market to just provide more convenient access to care anywhere and everywhere you can do it. So that would be my thought process on that.
Okay.
Did I go over again?
No, you didn't. You didn't do too bad that time.
Thank you.
You did okay. We'll let you stay in the game a little bit longer, even though there's a bit of a delay there. You must be down.
You got to start kicking people off. Just kick them off the call when they go over. They cut off completely.
I got a feeling you're down at Red Flag Farm and the reception's not good at spots down there. All right. Dr. Dickerson, it gets challenging to get employees and members of health plans to make different decisions. So how do you steer employees out of the traditional plan onto a bolt-on solution like yours?
Got to be great plan design. Number one, zero out of pocket for imaging or small copay. I had a independent TPA that put in a $375 copay. That's not a copay because most of our exams don't cost $375. It's a maximum out of pocket. So the plan design has to be right. If the mammography is included, if breast imaging is included, and 40% of the employee base is having a mammogram every year, that gets people using us in a low stress situation, and they're more likely to use us in a high stress situation. Employee education is just huge, though. A lot of people don't realize they don't have to go down the hall at their doctor's office. They can go across the street and not be subject to their copay and deductible.
Yeah, one follow up there, because I love that when you say it, it's more like something I would say. Talk the down the hall mentality. Like when my father practiced, he was doing his job. If they had a sonogram machine in their office, as you know, he's OBGYN. But if something else was needed, he'd say, hey, Betty, you need to go down the hall, to the hospital. Talk about that real quick.
Okay. 70% of doctors in this country are employed by or subsidized by hospital systems. The cost of care all the way through the episode of care is around, my best estimate, I've seen it published in the 2.5 times range, but I really, from the claims data I see, it's the 3 times range. So 3 times more expensive all the way through the episode of care. And we find that, pretty much to hold up that way in our claims data. Once we show our savings, we're saving at least pre-COVID 70%, COVID 60% on the medical imaging spend.
That seems quite cartelish, those numbers you share.
Oh, yes, sir.
Murph, what are some of the examples of specific ways fair cost impacts FLAACO members?
Well, I think Dr. Dickerson hit the nail on the head. It really does come down to a dynamic plan design as opposed to the static plan designs that we're used to from our friends, the major carriers. But we're big fans of ACOs. We have a very distinct community feel. We want to make sure healthcare dollars are left in the local community as opposed to sent to Wall Street. So a lot of our work is to eliminate the noise from middlemen that physicians and ACOs see when they're dealing with the bigger insurance companies. We try to eliminate barriers to care so that I think we have a dramatic impact on proper protocols and compliance. And very importantly, through a weaponized plan design, not only can we control and eliminate the hassle of pre-authorization and pre-certification, but we can get our providers out of the collections business. Once again, making insurance a meaningful and real benefit to the employee, as opposed to leaving them in a situation where the out-of-pocket is so high, they may as well not have any insurance because they can't afford the out-of-pocket. We even have procedures where we can pay for things in advance on a cash basis, making cash flow king for the ACO.
Okay. Tim, I really don't want to ask this question as a actual COVID survivor myself. Boy, I'm hesitant. I'm just about worn out on the discussions. But what is the biggest long-term impact to your ACO, or that you see as a provider group due to COVID?
Definitely the biggest thing that we've seen has been mentioned here a couple times, and that's telemedicine. So we were already providing telehealth services for our psych programs, but pretty much within about 2 or 3 weeks, we converted our entire visit population for all of our patients to telehealth, and so about 80% of our visits went to telehealth all through the COVID period. Now we've moved back into assisted livings and memory care buildings again, seeing patients in person. We're probably 70-30 now in person, but during those early months, it was pretty much all telehealth. And I think the long lasting impact of that is now that the payers are all continuing to pay for payer health, including telehealth, including Medicare, is that where we saw people going into the ER on a weekend or something, if we weren't in a facility, now they're calling us and we can do a telehealth visit on the weekend. And we think it's going to have a significant impact on necessary utilization for the ER and for inpatient hospital stays, which often our ED visits get converted into. So we're pretty excited about telehealth, and there was some reluctance in the early on months of the buildings because they were so locked down. Assisted livings and memory care units were so locked down because of COVID and having these vulnerable populations, but they pretty quickly realized that if they weren't getting some care and getting scripts refilled and getting the patients maintained, that they were having worse healthcare problems than COVID. And so it was pretty interesting to watch the industry morph and adopt to telehealth over the course of the COVID months.
Okay, thank you, Tim. Kellie Jackson, it's interesting. We all want to make sure we are paying a fair price for something, fair cost, no pun intended. How does an employer understand they're getting a good deal from an ACO?
We need to benchmark, what the cost of care is, and certainly Medicare, because there's really no other good benchmark. Medicare is what we use. So Medicare costs, Medicare payments are derived from the cost of what the care is. So it's, it's based locality. If it costs more to deliver care in Los Angeles than it does in Birmingham, then those adjustments are made. For across facilities, outpatients, all based on wage index, inpatient, a lot of things to consider in the cost of care. Here in Dallas, if you go have a hip replacement down at Parkland, it's trauma 4, it's teaching doctors, runs the ER 24/7, different cost for that facility to provide that care versus the hospital down the street here in the suburbs. So I think, using Medicare as a basis is a good start. And when you're looking at your direct contracts and whether you're doing reference-based pricing or direct contracting or whatever, understanding what the cost of that care is and using Medicare as a basis is what we have today in this country. And so you can benchmark, what you're paying for certain services to what Medicare would pay. And then, of course, you got to add something to it because it's going to be hard to get commercial payers to accept, just 100% Medicare. So you do have to increase it to a reasonable, amount above, just base Medicare.
Okay, thank you. Thank you. Chris, you've often said a phrase that we love and we use often. You always say to an employer, how many of your employees, Mr. and Miss Employer, would vote for single payer right now? And you often always compare them to some of these other high performing health plan models that we're discussing today, where most of those employees would probably say, we love what we have, we don't want single payer. Talk about go ahead.
No. I mean, I think it's such a good question. And I think there's so much data out there already around this. Like when you talk to an employer that has an on-site clinic or has solutions, baked into the plan, like some of the ones you're seeing today, or maybe even has a great partnership with a local ACO, and primary care is addressed up front, and there's not a lot of balance billing going out. If you change the subconscious interaction of healthcare access every time that person interacts with the healthcare system locally, right? Every time they're using their insurance card or paying cash or paying a reference-based price or paying a negotiated image rate, their experience in healthcare becomes a good one versus a negative one. Employer groups that have not done anything innovative for their employees when it comes to health insurance plan design or trying to find these solutions, the entire market is those are people that rightfully so think the grass is greener on the other side. And I don't blame them for saying, hey, single payer system's got to be better than this balance bill and these outrageous, rates that I'm paying every 2 seconds. We've caused it ourselves, with a lack of transparency and a lack of innovation when it comes to healthcare. So I think the more convenient access we can provide, the more innovative we can be as an industry, the better off we all are to continue private healthcare in the United States. If not, there's going to be one payer eventually, and that's going to be the federal government.
Y'all think I should mute him? I mean, he's a pretty loquacious fella. He makes me look like I'm short-winded. Anyway,
I have to say one other thing, since you just said you were going to mute me. My only other thought on this is, if you go to a single payer system tomorrow, you know who the largest employer of physicians is in the United States?
yeah, I do.
It's Optum. It's United Healthcare. So make no mistake, folks, all of you ACOs out there watching this panel and watch this call, they want your market share. They're employing all of the doctors you went to medical school with in much larger numbers. They're extremely well positioned for a single payer system. They will be the largest biller of that single payer system if it ever stops. So you've got to put your feet down as an ACO and as an innovator, and you've got to come to the market with better solutions, or you're going to give them your market share when it is a single payer system, because they'll have more bandwidth than you, and they're going to move quicker. So that's all.
Thank you, Mr. Yarn. Barry Murphy, what impact does fair cost have on actual insurance costs? Because we know about, and I'm sure you'll discuss, fixed costs being admin fees, stop loss premiums, variable cost or claims, which is where you can really make hay. What does it do to the fixed cost in the reinsurance area?
Well, I want to bridge off of what Chris just said. I was remiss in not mentioning a very real part of the fair cost effort is to allow ACO. Imagine an ACO being able to talk directly to the end user without having to go through an insurance company that is looking to overregulate and bump up the price. We construct plans that meet the needs of the providers and recognize those needs and communicate those needs effectively. Most members of an ACO want to deliver care. But as it relates to the insurance costs, yes, our fixed costs are higher because we brought more resources, but the return on that investment is enormous. When you talk to a reinsurance company about having diabetic management, remote monitored, and protocols, making sure prescriptions are being taken properly, eliminating the barriers to care so that people are compliant. That's just one example. And Carl, as you know, one of our clients in Florida experienced a reduction in their healthcare reinsurance costs for the second time in that reinsurance company's history. And in that particular instance, we took the medical spend down from 2.2 million to about $1.4 million. And the reinsurance world is coming to recognize the quality and the impact of active management through fair cost, and are expressing their excitement and interest in the reinsurance factors that we're getting for our clients and prospects.
One quick follow-up to that, Barry. One of the things that we hear a lot from physicians, and again, hearing my father, he spent as much time on the phone with insurance companies as he did taking care of patients, dealing with pre-certs and prior arts and peer-to-peer reviews. Can you comment about that? Is there what you can do with your program?
Well, again, we at least allow the physician community, and in particular the ASO, to have input on designing what is appropriate for pre-authorization and pre-certification. We don't want, again, barriers between physicians and their patients. We want to facilitate that. We want to make the out-of-pocket expenses for the employees lower so that they can work closely with their physicians in designing and implementing their care.
All right, thank you. Dr. Dickerson, is direct contracting for imaging, is that available nationally, regionally? And what is the scalability with how many practices within an ACO could you actually serve?
Our company is national. We're not in a few states yet because we no longer build out the network unless we have a large number of lives to leverage great pricing. But if we have a patient in an area that we don't have a facility, we're the experts in shopping for medical imaging. And so we go out and shop for that patient and get usually the same kind of deal we can with a direct contract with a facility. But if you're a small group or ACO, you can certainly contract with a regional provider. But what we bring to the table is being the radiologists and reading the studies to assure quality. Or if we're not reading the study, we have peer review privileges. So it's a kind of quality that you can't put any metrics on that. We're all MD Anderson trained subspecialty radiologists, and that's just a big difference between us and a bureaucracy.
Okay. All right, thank you. I'm going to throw this out to everybody, guys, and this is the lightning round, so you got to be lightning quick to get it done. So here it is, and I'll start. I'll go Tim, Dr. Dickerson, Chris, Kelly, and Barry. Y'all, hope y'all can remember that. I'll test your mental skills. Who on the panel today thinks they can directly help ACOs from a population health management standpoint? And how, if at all, can you directly improve the patient panel data that leads to higher percentage reimbursements for the ACOs and their doctor partners? Tim, quick. We can't hear you, Tim. You're muted.
You're muted.
There. We focus on these high-risk patient populations, and they're populations that it's really difficult for most ACOs to get to. We're out in the field, we're mobile clinics, we have nurse practitioners and physicians and care coordinators and stuff that are out in the community. And we're really servicing populations that aren't served well by the traditional healthcare system. So in that context, I think we have a unique value proposition for those patient populations.
Doc Dickerson. You're muted.
You're muted.
We do it by constant education of the employees as to the need, especially if you're high risk of getting that mammogram, getting those screening exams. And we actually, make it easy and affordable for them to get those studies. There's so many barriers to whether it's not being English as the first language. Whatever those barriers are, we try to remove those and get them to the medical imaging exams that they need. We also identify high-risk patients or a patient with a new cancer diagnosis, new stroke, and we get that back to the medical management company so that they can help get that employee to the best, highest quality, most affordable site for that.
Okay, thank gosh. As usual, the first two that speak take a lot of the time up sometimes, especially when they're muted. So we got to be fast. Chris, you're next.
Convenient access
quickly.
Yep, convenient access to care. Tim just hit on it. It's working for their ACO, mobile clinics, deployment, hitting rural areas. I think if you really look at integrating, you've got a medical person that trains someone on using Zoom like we're on today, or Microsoft Teams or WhatsApp. You can literally plug in the remote patient monitoring devices on site at these populations. Tell them they can call this ACO directly using WhatsApp or whatever telemedicine platform they're on after that, and have a high amount of success increasing all of your patient panel reimbursement rates as well.
Kellie Jackson, we have about 40 seconds left. You've got 20 seconds and Murph gets the other 20. Fire away.
Hi, we would be providing transparency of cost to our other partners that are on this panel so that they can help with the population health. Short and sweet.
Again, our objective is to create access for the ACO with the direct consumer. It's not like Field of Dreams, build it and they will come. You have a wonderful ACO. We actually have medical professionals, the CFO of a hospital, that will go on an initial call with us to the customer. It is refreshing. They've never seen it before. They want to talk to you. We can help facilitate that.
Well done. All right. So let me wrap it here. Anything else anybody want to share? Nothing? All right. Let me get this back. All right. So
Yes, we'll answer questions that they've done in the chat now.
all right. So again, thank you. And nobody really went way over too much. I do want to say one thing before I finish and thank everyone. Look closely at that hat, please. Go Dogs. All right. So thanks to FLAACOs, Nicole and Sam, with a great team. And thanks to PayerCompass, Bluestone, Walk on Clinic Agreements, and FairCo. Thank you guys all for being a part of this session.
Thank you.
Carl.
All right.
Thanks for having us, Carl.
All right.
Have a
you
good
got
day.
it.